Hello, my name is Dr. Rajiv. Welcome to my education channel, YouTube Surgery and Orthopedic Education. We shall today discuss what are the primary, secondary, and tertiary surveys in a severely traumatized patient. In the end, please subscribe to our channel and give us a like if you find the discussion useful. So, let us not waste time anymore and start the discussion. Severe trauma with multiple injuries to different body systems poses big diagnostic and treatment challenges. The early assessment and management of severe trauma begins in the pre-hospital setting. You can find a video dedicated to this topic in the playlist Trauma Evaluation and Management. The link has been given in the description box also. When a traumatized patient is found at the scene of an accident, the pre-hospital system should notify the receiving hospital before the patient is transported from the site of occurrence. The receiving hospital activates the trauma team so that the treating personnel can wait for the patient's arrival in the resuscitation room. Trauma team should involve the emergency department, anesthesia, critical care, orthopedics, and general surgery personnel. Key information in the pre-alert message includes age and gender, mechanism of injury, injuries recorded, vital signs like level of consciousness, pulse, blood pressure, respiratory rate, and Glasgow Coma scale. The trauma team applies the principles of advanced trauma life support to rapidly assess and treat life-threatening injuries during the primary survey. Code Red Trauma Call. In large volume trauma centers, there is a high level trauma team activation system for severely injured patients called Code Red Trauma Call. Code Red is a series of interventions that should be completed in order to prepare for receiving a critically injured patient. It triggers the attendance of the most senior physicians from relevant departments before the patient's arrival and pre-hospital activation of massive transfusion protocols. Link to the massive transfusion protocol video has been given in the description box. The trauma team applies the principles of advanced trauma life support to rapidly identify and treat life-threatening injuries. The trauma team should work together concurrently instead of sequentially, such as while the anesthetist assesses and manages the patient's airway, surgeon will be assessing and managing the patient's bleeding and so on. The trauma team leader is the most senior physician who briefs and prepares the team, coordinates the sequential activities, allocates tasks, manages time, interprets findings, and plans the next treatment modality. Code red is triggered in situations such as in all traumatic cardiac arrest cases, in severe mechanisms of injury, for example, road traffic accidents, falls from more than 20 feet height, bomb injuries, in hemodynamically unstable patients, that is, systolic blood pressure less than 90 or heart rate more than 100, in injuries with potential for massive hemorrhage, such as pelvic fractures, penetrating trauma, etc. Primary survey or cABCDE of trauma care. The primary survey or initial assessment and management of a severe polytrauma patient has been designed to identify any actual or imminent life threats and to treat them immediately to provide optimum resuscitation and survival opportunities. Avoidance of hypovolemia and hypothermia should be the goal to preserve vital organ function. It manages the most immediately life-threatening pathologies first and follows the cABCDE sequence, where C stands for control of catastrophic hemorrhage, A for airway and cervical spine control, B for breathing, C for circulation and bleeding control, D for disability, and E for exposure. The primary survey is conducted simultaneously with the resuscitation. Control of catastrophic external hemorrhage. The past 20 years of experience in war zones has shown that controlling the exsanguinating external hemorrhage from massive arterial injury should be given priority over airway management. Ongoing bleeding must be controlled immediately by the application of pressure and packs directly onto the bleeding site and artery if recognized. If pressure and packs fail, a simple improvised tourniquet proximal to the wound should be applied. The time since the tourniquet is applied must be recorded on the patient. Airway and cervical spine protection. The cervical spine of all trauma patients should be immobilized and protected throughout. At the same time, an assessment of the patient's airway also is made. It is done by asking a question. If the patient can speak effortlessly, the airway is open. If the airway is found compromised or obstructed, first clear the airway by suctioning secretions or blood or foreign bodies. Then perform simple airway maneuvers such as a jaw thrust or chin lift. A jaw thrust is preferred if cervical spine injury is suspected. Then insert an oropharyngeal or nasopharyngeal airway. Advanced airway maneuvers, such as the insertion of a cupped endotracheal tube or a needle cricothyroidotomy, should be done by an anesthetist. Breathing and ventilation. This assessment should start with inspection itself. The physician should look for significant chest wounds, tension pneumothorax, massive hemothorax, flail chest, paradoxical chest movement, or asymmetric chest wall excursion. Then auscultate both lung fields to identify decreased or asymmetric breath sounds. Decreased breath sounds may be a sign of pneumothorax or hemothorax. A combination of decreased breath sound with either tracheal deviation or hemodynamic compromise can point to a tension pneumothorax. This, if present, should be treated with needle decompression followed by a tube thoracotomy. Cover open chest wounds immediately on three sides to prevent atmospheric air entry into the chest. If there is breathing difficulty due to a flail chest segment, positive pressure ventilation should be considered. Of note, all trauma patients should receive supplemental high flow oxygen. Circulation and bleeding control. Palpating peripheral pulses can provide first-hand information about the patient's cardiovascular status. As a guide, systolic blood pressure must be 60 mm Hg or higher for the carotid pulse to be palpable, 70 mm Hg or higher for the femoral pulse, and 80 mm Hg or higher for the radial pulse to be palpable. All patients require adequate intravenous access with at least two large bore peripheral IV catheters, for example, a 16 gauge or larger catheter in adults. For patients in whom access to a peripheral IV catheter is difficult or not possible, intraosseous needles can be placed in the proximal tibia. After the emergency is over, the needle should be removed and alternative access is established to prevent osteomyelitis. Blood should be collected for cross matching and laboratory tests, including hemoglobin and venous lactate. In shocked patients, the skin may be pale, cool, and sweaty, the pulse rate over 100 per minute, and the systolic blood pressure below 60 mm of mercury. 4 life-threatening injuries must be identified promptly. These are massive hemothorax, cardiac tamponade, massive hemoperitoneum, and unstable pelvic fractures. A pelvic binder should be applied to all shocked patients following blunt trauma until a pelvic fracture has been excluded. The fluid resuscitation and identification of the source of hemorrhage should be done simultaneously. Disability and neurological status. The Glasgow Coma scale score should be calculated on admission for all injured patients. The Glasgow Coma scale reflects the potential for neurological injury. It is useful for triage, treatment, and prognosis. The practice of log rolling of the blunt trauma patient to examine the back is minimally useful, delays the whole body CT scan, and harms a patient with a pelvic fracture. The pupil should be examined for size and reaction to light. Core body temperature must be recorded. Neurological examination is mandatory before administration of muscle relaxants for intubation. Subtle changes in mental status can be caused by an increasing intracranial pressure, hypoxia, hypercarbia, or hypovolemia. This should prompt an immediate re-evaluation of the ABCs and lead to a suspicion of head injury. Early whole body CT scan will readily identify the majority of intracranial and spinal lesions. Glasgow Coma Scale. The Glasgow Coma Scale is used to describe the general level of consciousness in patients with head and brain injuries. The GCS is divided into three categories: best eye opening, best motor response, and best verbal response. The score is determined by the sum of the scores in each category with a maximum score of 15 and a minimum score of 3. Serial findings should be recorded on a coma scale chart. This enables observations to be clearly communicated and the trends rapidly appreciated so that any improvement or deterioration in the patient's condition can be seen. In addition, a scores can be documented numerically as a shorthand to quickly record findings such as E1, B4, M6. The shorthand numbers can also be added together to give a total coma score like E1, V4, M6 equal to 11. The total coma score provides a summary of the severity of the patient's condition, but this score does not give a more detailed description of each response category, which should always be recorded separately in addition to the total score. The score is interpreted as mild, moderate, or severe. A GCS of 13 to 15 indicates mild brain injury if the patient is awake and presents with confusion but is able to follow instructions and communicate. A GCS of 9 to 12 indicates moderate brain injury if the patient is drowsy or obtunded, can open his eyes and localize painful stimuli. A GCS of 3 to 8 indicates severe brain injury if the patient presents as obtunded to comatose, is unable to follow instructions and or exhibits decorticate or decerebrate posturing. Exposure. The patient should be completely undressed and exposed to allow a thorough and systematic clinical examination so that no injuries are missed. They should then be recovered with warm blankets to protect them from hypothermia. Hypothermia aggravates the coagulopathy of bleeding. Therefore, every effort should be made to maintain normal body temperature by using warm blankets and trolleys and warm fluids during resuscitation. Log rolling harms patients with severe pelvic fractures by disturbing blood clots. Log rolling should not be done until a pelvic fracture has been excluded radiographically. If at all, patients need to be moved during their primary survey, such as when taken to the CT scanning room, a 20-degree roll with spinal stabilization should be used. Whole body CT or WBCT. The sites of major hemorrhage in trauma patients are extremities, abdomen, chest, and the pelvic region. Clinical examination, ultrasound, and radiology rapidly confirm or exclude significant bleeding from these sites. Multiple sources of hemorrhage are frequently present in blunt trauma patients. Head to toe contrast enhanced computed tomography or whole body CT scan is the gold standard investigation in multiply injured patients with deranged and unstable hemodynamics. Whole body CT or WBCT should be performed during the patient's resuscitation. A detailed report should be available within 30 to 60 minutes. However, it should not be performed on the basis of the mechanism of injury alone or for scanning selective body systems. Traditional chest and pelvic radiographs may be omitted if a rapid whole body CT scan facility is readily available. A focused abdominal sonography for trauma or fast scan is also useful to locate the major source of hemorrhage. In extreme conditions, immediate laparotomy in the operating room with a pelvic binder applied and not removed may be performed to control internal bleeding. In this scenario, a WBCT scan or whole body CT scan may be done after surgical control of the hemorrhage has been achieved. Secondary survey. The secondary survey starts after the primary survey has been completed. Immediate life threats identified and managed, and the patient is stable. Continue to monitor the patient's airway, level of consciousness, oxygen saturation, respiratory rate, heart rate, blood pressure, and capillary refill time. Remain alert for any unexpected deterioration in these parameters, which require reassessment and management of any missed or new life threats. The key elements of the history in secondary survey may be remembered as the mnemonic AMPLE, AMPLE. In AMPLE, A stands for History of Allergies, M for medications currently used, P for past medical history, L for last meal or other intake, and E for events leading to the injury. After ample history, a thorough physical examination of head, neck, spine, abdomen, chest, and the nervous system should be done. Tertiary survey. The tertiary survey is the final opportunity to enable the identification of undiagnosed missed injuries that were not detected on admission in a large group of patients who were intubated and unresponsive at this point. The tertiary survey is re-evaluating patients 24 hours after admission after they are extubated and become responsive by means of physical re-examination, review of complementary tests, and request for new tests if necessary.